Welcome to the Spine MDT. This video is about anterior lumbar interbody fusion. Perhaps you're about to have this operation, I've offered it to you, or another surgeon has. It's about the indications, the procedure itself, the benefits and some of the risks. This is part of a series of videos on my YouTube channel about the different operations we do and how I do them. Please subscribe to the channel as I post regularly every week for useful information about back pain and spine care in general. Please also visit my blog page, the link is below, which also covers useful information about the spine and spine care. But in terms of the anterior lumbar interbody fusion, it's predominantly there to treat degenerative diseases of the spine. There are very few indications that require this surgery. Some of that is covered in this video here on my blog page, so have a look at the link below, but let's dive into it. So the operation is a way of fusing up two vertebral bodies of the spine by going in through the front. I've previously done the blog on a more popular approach, or should I say more common approach, going through the back of the spine, except I do that through a minimally invasive technique where a disc is removed, a cage is put in its place, and a construct of 4 screws and 2 rods are placed in the back of the spine to secure it all. But there are a couple of scenarios where sometimes it's better to go in through the front of the spine. One quite rare reason to fuse the spine is if you can demonstrate that the pain generated in someone's back is genuinely due to disc disease. Fusing the spine for back pain alone without instability rarely produces good results. A more common reason to fuse the spine is what we call a spondylolisthesis, for which I've done a separate video about, where one bone slips forward over the other bone, and there are different reasons for that. The reason I would do an anterior approach instead of the posterior approach, i.e. the back of the spine as I previously described, is usually for me personally is if I'm working at this level here, L5S1, where there's usually quite a larger angulation at this level in the normally aligned spine, and I'm trying to restore that normal angulation. You have to fit in a bigger cage between the discs in the disc space to really jack up the height of this bone. So for me at that level, depending on what your x-rays look like when you're standing and what we're trying to achieve, sometimes the approach through the front of the spine is better. Alternatively, if you've had multiple operations through the back of the spine, this way can avoid scar tissue. So patients are put to sleep under a general anaesthetic. We give intravenous antibiotics to help prevent infection, and we also use a urinary catheter purely for the duration of the operation, just to stop the bladder filling up excessively. Because we're going in through the front of the abdomen, the incision is quite low down, sort of across the waistline, hidden in the underwear waistline, so it can hide the wound quite nicely. And I usually do this with the aid of a vascular surgeon. Now, some spine surgeons do this alone. I personally think it's far better and safer to do this with a vascular surgeon, someone who's used to handling not only the bowels but the actual major blood vessels that sit in front of the spine. A hemorrhage from these vessels can be catastrophic, so I personally like to have someone there who knows how to handle the vessels. That maximises the safety of the patient. So once the vascular surgeon has mobilised the blood vessels and given me safe access to the front of the spine, here we have a picture of the front of the spine here, and these blue things are the discs between the bones. The disc is removed completely so that I've got good visualisation that all the nerves at the back are completely free and the bones are completely exposed and roughened. Then this is the cage that's inserted through the front with these 4 screws here. So this is a picture of a type of cage that's used, and the ones I like to use do have 4 screws as a minimum for good anchorage and security. And once it's in, you put the screws in, 2 in the bone above, 2 in the bone below. You also use some x-rays to ensure that you've got it at the right depth and all the screws are in the right place. This is a post-operative CT which shows the cage in the disc space, and the disc space here is nicely jacked up, and And what I was talking about earlier, this is the sort of angulation you want, or the height you want at the lowest disc level, L5S1, compared to the one above it. There's usually a nice big angle here, which is what you want. And you can see the screws nicely embedded in the bone, the cage sitting flush. This scan was done approximately 6 weeks later, and you can already see a sort of bony channel forming through the cage. So the idea is this bone here over time fuses up with this bone here. That creates stability, stops any kind of micro movement, alleviates back pain. Not always, but sometimes, depending on the instability of the spine before the operation, as well as having the cage in the middle of the disc space, we sometimes do put screws in the back as well, just like with the TLIF operation, the minimally invasive TLIF. Through very small puncture incisions in the back, you can put 4 screws in as an extra backup. That's usually on a judgment on various x-rays and tests that we do before the operation. Sometimes the 4 screws in the cage alone do suffice, and there are some studies that demonstrate adequate stability with that alone. So once the metalwork's all in, we're happy with the x-rays. The vascular surgeon who helps me has a final look at all of the blood vessels before closing up, and that's usually in layers with an absorbable stitch just below the wound, and then we remove the catheter before waking you up. I usually give a couple of doses of antibiotics afterwards just to help prevent any infection, and then we try and get you up pretty soon after the operation. In the context of instability and nerve compression, it can help alleviate the pain down the legs as well as the back pain. And if you go through the right process of identifying patients where you can prove that the back pain is caused by the disc disease and they've failed all the other options of surgery, you can experience a good alleviation of back pain as well. But as I mentioned, it's extremely rare that I would do it for that purpose alone. Now, every procedure we do has some risks. The predominant ones we worry about when we're operating around the spine and the nerve to the bladder, the bowel and your legs are paralysis. That's extremely rare, but theoretically there is a risk of damage to all those nerves that can cause paralysis, and incontinence. That's an extremely rare occurrence. There's a risk of damaging the major blood vessels at the front of the spine, the aorta, the iliac vessels that deliver blood to your legs. These are big, wide, bulky vessels. The tear of those can cause a catastrophic hemorrhage. If they are torn, that can be repaired and prevented, and that's why I like to have a vascular surgeon. It's their role to manage these vessels. They manage these kind of blood vessels on a high frequency and can deal with these complications. I believe that's the safest way to do the operation, and it does massively minimise that risk, in my opinion. You can have problems with your bowels. Now, the approach itself to get to the spine, you don't actually see the bowels if this is done through what they call a retroperitoneal approach. Your bowels are contained in a lining called the peritoneum, and as long as you stay outside of that lining, the vascular surgeon kind of finds a plane around them, moves it out of the way. There are extremely rare circumstances of damaging bowel, of the bowel, which may need further surgery for a repair. And there's also risks of infection, as with any operation. That usually requires antibiotics if it's superficial, but sometimes if it's very deep in the spine, that may require further surgery to remove the metalwork and wash it out. Again, that's extremely rare. The ureters and the structures that go from your bladder, this is particularly in men towards the penis and through the prostate. There is a phenomenon of retrograde ejaculation where during intercourse the semen goes back towards the bladder rather than outwards. It's extremely rare, but it has been described, and as part of the consent process it's important to mention that and be aware of that. The general risk to life from general anaesthetic is extremely rare. Specific to this operation, the risk to life from a catastrophic hemorrhage is minimised, in my opinion, by using a vascular surgeon. It's still very low. There are also risks of pulmonary embolism, so blood clots in the lungs or in the legs. We try and minimise this by giving you some blood thinning medication soon after the surgery and also getting you mobilised very quickly. In terms of recovery, you can usually expect 1 or 2 nights at the most in hospital. I always advise patients undergoing lumbar fusion to try and take about 6 weeks off work. Now, in that time, I expect you to be mobile, relatively active in terms of walking, doing the exercises that physiotherapists give you to try and get the best result in rehabilitating your spinal muscles. But I don't want you being committed to an 8-hour day in front at the office, sat at a desk. To get the best results, it's best you work on rebuilding your core strength. But you should notice in that time that actually you're relatively mobile, and there's a big difference. Details of the procedure are also covered in the British Association of Spine Surgeons booklet on the operation. There's a link to that below, and I always give that out to patients when we're having our consultations about the operation. I hope you found that helpful. If so, please subscribe to the channel. I'll be posting videos every week. The goal of the Spine MDT is to find the least invasive solution that gives you the longest lasting results. We're able to do that by working as a multidisciplinary team of surgeons, pain specialists, osteopaths, physiotherapists, and chiropractors. Please visit us at spinemdt.com, or email us or call us on the number below, and we'll be very happy to help you. Thank you.